So we're going to start today and then hopefully finish this stuff up. There are quite a few slides, but we'll finish this up today. Does anybody else not have a score on Brightspace? Let me know. I don't know if they're... I guess they need to be released. I don't know. Okay. All right. I guess I'll release them. My bad. Okie dokie. All right. So we're going to start today by talking about interpretation of symptoms and symptoms themselves that would, and I guess personality and other traits that somebody might have. Okay, you can kill the... You don't have it. Nobody has them. And then on Wednesday, we'll finish up this chat about... And then talking about how patients and providers talk to each other about being ill and being sick and symptoms and all that stuff. And we're going to couch all of this. We're going to couch all of this in the United States healthcare system. Okay? Couch this in the United States healthcare system because while we could compare systems to even like US to Canada, they would just take a lot of energy just to be like, well, this is what the US does, and then this is what Canada does. I might bring it up every so often, but I'm sure you are aware of our healthcare system and what it is and what it's all about and all of that, right? This comic is a good illustration of that, okay? So just be careful when you go to the doctor and you just get tickled. Okay. That'll be $43,000. Thanks. All right. Switching to... Oh. I don't remember what this is. Oh, it's about pain. This is Funny or Die. That's right.
Something terrible is happening.
Something terrible is happening.
Something terrible is happening.
Something terrible is happening.
Health insurance executives are getting a bad rap.
As the healthcare debate heats up.
So this is from 2008.
Health insurance executives.
You might recognize some of these faces.
Things about health insurance companies and their executives. And it's got to stop.
These great businessmen are American heroes.
So why is Obama trying to reform healthcare when insurance companies are doing just fine, making billions of dollars of profit?
Obama, why?
Insurance companies need our support.
Obama, why?
Because they keep our selfish priorities in check when we can't.
Please, doctor, my daughter's dying. She needs medication.
Think about somebody else for once.
If my kid falls off his bike and breaks his leg, he should have to pay that money out of pocket, out of his allowance.
How else is he going to learn not to fall off that bike?
And insurance companies are detail-oriented enough to deny claims for things like typos. If you spell something wrong, do you really deserve surgery? I don't think so.
80% of the American public support the public plan because it would give quality care people can actually afford.
But when you think about it, who's really supporting it other than 80% of the American people?
And the public option would make insurance companies lower their prices and give better service in order to compete.
What's so American about competition?
But health insurance companies are huge.
They need to make big profits so they can afford to give their employees health insurance.
Believe me, that stuff's not cheap.
It makes sense.
Insurance company CEOs have a right to their American dream.
And it's 5 houses.
A private plane. $500 million in your pocket?
And a mini zoo in your backyard for exotic animals like a white tiger and pygmy horses.
Insurance companies offer you variety.
They can change the price and terms of your plan at any time or stop covering you altogether.
Do you want to get rid of those options?
So join us in the fight to protect our insurance company profits. They've looked out for our best interests for so long. Now we should look out for theirs.
And I'm not being sarcastic, not at all.
Hey, this message actually might be useful to some of you.
MoveOn.org political action is responsible for the content of this advertisement.
Yeah. Thoughts on this? Thoughts? I would love your thoughts. Both THOUGATS and also THOTS. You want the forbidden better insurance? I don't know what that means. I don't know what that means. Help me. Obi-Wan Kenobi. You're my only hope. Alright. More thoughts, please. More thoughts. And while you're thinking about the thoughts to that, I would like you to also include in chat answers to these, if you are so inclined to do so. This would normally be a longer quick write in class, but you know, you could just throw it up in chat if it works for you. Okay, just, you know, throw it in chat. Also, thoughts on the MoveOn.org ad from 2008, which is oddly and very nicely prescient. Do you like what I'm doing with my hands? I kind of like what I'm doing with my hands. Oh no, they disappeared because they're going into the out of the box. Discuss. Everyone's got a positive experience, although you might want to throw in a negative experience. You know. Nice, good times, Logan. I like that. Good stuff. Okay. More. You still haven't explained what forbidden better insurance is, though. Yeah, hospitals will do that. So most negative experiences do come from money. Gotcha. For insurance, I don't know if insurance can be better. But I hear what you're saying. So Katie has a part of the hospital that did your knee surgery. That's good. I'm glad that was okay. Allison, all of my nurses were super cool when I had surgery junior year. And one of them in like 20 minutes from me, so that was neat. So you just like go hang out. Yeah, negative experience for Katie. Getting desperate X levels of emails about explanation of benefits. Oh, desperate X level. I got you now. Emily, you cry when you get shots, blood taken, the nurses are always so nice. Well, that's good. I like that. Jaden, physical therapist, it felt like she truly cared about me getting better. Yeah, physical therapy. Physical therapists are cool like that. It's a pretty important profession. Caitlin, when you had shoulder surgery, they were very personal. Everything was stress-free. David, primary care is the best doctor you've ever had. Always seem to talk about the works of Michael Crichton. Hey, befriend the people who share your interests. I like it. Marissa, doctor was so nice about blood transfusion to calm nerves. Interesting. Aaliyah, growing up to ways, always great to get a nice nurse that was always gentle, having my yearly meltdown about getting a shot. Yeah. Stephanie, hospitalized, the nurses and doctors were really nice. Logan, I don't want to money. Yep. All of Fake God, Bali, Indonesia, cheap meds, native experience. Okay. State insurance is a scam. I'm not actually aware of the healthcare system in Indonesia. Thanks for sharing. That's it's interesting. Courtney in the hospital earlier semester, they started really awesome, but then they switched doctors and she would give me pain meds until my mom threatened to put everyone on the floor. Woof! Excruciating pain for 5 hours. That's a bummer. Braden, positive. My doctor was a pretty cool dude and is always helpful. Negative. The wait time to schedule an appointment. Yeah. Teeth. Physical therapy. Had a great experience with PT and PTAs. That worked. It's nice. Physical therapy is not cheap, Katie. Yeah, but I mean, it depends on your insurance. What's covered, what's not, right? How many visits are covered? Like, what insurance deems as effectively healed for any given thing, right? Sarah, during first knee surgery, I was scared. Honestly, no idea what was happening, and no one was telling me anything. So I was freaking out. Yeah, that is dicey. I'm glad your second one, and boy, woof, second knee surgery. That's rough. Kat, when you had the flu, and my doctor was really cool and didn't try to get me to buy an expensive medicine for the flu? That's strange. But I'm glad they didn't, because that would be ridiculous. They just told me home things I could do instead. Well, yeah, because pretty much nothing really destroys the flu, so it's a good thing they didn't try to get you to do anything. Deanne, when I was in physical therapy in high school, my therapist was awesome. We had a lot in common, super supportive. Going through a bad breakup in your senior year, that's cool. That's cool. Strong experience, but super cool dude. Jordan, growing up, I have some very nice doctors. All right. Cool. I'm glad you guys have had such good experiences with, like, physical therapists. Another, Kelsey jumping in with another one. 3rd grade, pneumonia. Oof. Spent a week in the hospital. Small child, terrified of the machines and needles. Yeah. I hear ya. Braden, my mom is a physical therapist and I hate it so much. Neurologist fights for insurance for... that's really cool. That's really cool, yeah. Find a doctor that will handle your insurance battles for you. Okay. Olivia, PT gave me some cookies when you were in pain. That's homemade touch right there. I like that. All right. So let's talk about symptoms and the people that experience them, right? So, like I said, today is going to be all about symptoms and symptomatology and what kinds of symptoms there are, right? Because this is the first step into in seeking care, is to determine, like, is something wrong with me? And if it's really wrong, do I need to go then get some help, right? Some more expert help, right? So not everyone is going to recognize that they have symptoms right off the bat, okay? This has a lot to do with personality traits, okay? The first sort of personality trait that I want to talk about is readiness to identify symptoms, readiness to recognize symptoms, okay? And this brings up hypochondriacs, or the associated term hypochondriasis, okay? Hypochondriasis is a trait slash minor mental disorder, okay? I say minor because it's not really a psychological disorder like depression or anxiety or schizophrenia or something like that. But hypochondriasis can be clinical, okay? And so hypochondriacs obviously have the delusion or false belief that they have a disease when none is present. WebMD has really helped grow, I think, hypochondriasis in the general public, just broadly speaking, right? Neuroticism, the big 5 trait of personality, neuroticism, the opposite of emotional stability, depending on how you learned what the big 5. So here we have somebody like Eeyore, right? He's always sad, okay? He's always sad, he's always depressed, he's always thinking about how life is terrible. I mean, dude's gonna catch a cold getting rained on all the time, right? He's gonna catch a cold. So people who are high in neuroticism are very quick at recognizing when something is wrong, okay? And whether or not it's wrong is is up for debate, right? Like the sniffles or something like that. It's like, oh my god, I have nose cancer. No, probably not, right? So they're quick to recognize symptoms, and then they're very quick to report those symptoms, right? To a healthcare provider, nurse, doctor, nurse practitioner, somebody, okay? And it generally follows the higher N you have, so the higher neuroticism you have, the more you're likely to catastrophize those symptoms, okay? So make it more serious than it actually is. Or exaggerate symptoms, okay? So I have a cough, for example. It's a periodic dry cough. An exaggeration of that periodic dry cough would be, especially like right now, would be like, oh shoot, do you have COVID? Oh man, that cough is ridiculous, right? So you want to, so high neuroticism generally is predictive of how the person reports those symptoms, like how close they are to actual reality, and then how much this impacts their life, right? Catastrophizing it. Right? This is the end of the world. This is the end of my life. I'm gonna die, etc. So the higher the N is correlated with bigger exaggeration, more catastrophizing. Okay. There are attentional differences too. And Jamie Pennebaker, we just talked about him a little bit when we were talking about coping. He's the guy from the University of Texas at Austin, right? The main campus for UT. And he's the one who did the writing, the expressive writing studies. Like that's most of his work is the expressive writing studies. But one of the things that he did, right, because he's a health psychologist, one of the things that he did was he asked people about their distraction levels, right? So how outwardly focused their attention is versus how inwardly focused their attention is. And so in the 1980s, he showed that people who are less distracted, who have more time to think about what's going on inwardly, are quicker to recognize their symptoms and then report those symptoms more often. And what I mean by reporting is that like they go tell a doctor or a nurse or something like that, right? Not just saying like to your friend like, hey, I think I have like a lump under my arm. I don't know, maybe cancer. I don't know. So if you are inwardly focused, that is, your attention is inward as opposed to outward distractions like doing stuff, having conversations, working, playing video games, you're more likely. So that's outward focused attention. You're more likely, if you're inward focused, to report and express those symptoms. Okay. There are situational factors as well. So you could be an inwardly focused person, but if the situation takes your attention elsewhere, then those situational demands will take precedent over your inward focused attention. Okay. So this class has likely, dare I say likely, increased your awareness of your unhealthy behaviors and habits. Raise your hand if you think that's true. Raise your hand if you're like, yep, that's me. Yep. Because every time I teach this class, I'm just like, man, I just have some of the worst habits in the world. Should I stop them? Probably not. You know, life's too short, right? Especially the health behavior change plan, right? It makes you wonder to yourself, is this me? Right? Do I do that? Right, so that's a situational factor, and another situational factor, which I did not include on these slides, but I intended to mention it briefly, is another situational factor is the coronavirus and COVID-19 stuff that's going on right now, right? And so, a situational factor for me is making sure that I'm breathing okay, making sure that I wear a mask out in public, only go out when we need to go out, like, grocery shopping and that sort of thing, right? And so those situational factors play a big role right now in whether or not symptoms are this, that, and the other thing, okay? And whether those symptoms match what people are reporting about COVID, etc., right? And you may be doing some of the same things, okay? And an interesting phenomenon with situational factors and this idea of interpreting your own and recognizing your own symptoms is something that's called medical student's disease, or medical student syndrome, you might see it as, okay? And so this specifically afflicts medical students, and so it's a false belief, a delusion, that they are or have the various diseases that they have to study, right? Because that's a huge part of going to medical school, is learning about all of the ways that the human body fails, right? Human body just fails constantly. And so you have to learn about how the body fails. And so when you do, you end up with a situation potentially called medical student's disease. And I wanted to play this real short clip from the final season of Scrubs, where basically JD has moved on and Donald Faison as Turk becomes a teacher and teaches a new group of med students. I really enjoy it. I enjoy it.
Even though Dr. Turk warned us about med student syndrome, we couldn't help ourselves.
Dr. Turk, I've got scurvy and rickets. How did I get all the pirate diseases?
That's a walk in the park compared to my early onset dementia. Where's my phone?
Actually, Cole does have a weird mole on his chest.
Man, forget that mole. I'm more worried about the pain in my throat. The T-pain.
This is at the height of...
Listen, guys, calm
height
down.
of the auto-tune.
You're all fine. Everything's good. That's a bruise. You're just ticklish. And you, my friend, you got ink on your tongue. Stop eating your pins. Cole, the mole on your chest... Well, actually, the mole on your chest is something we need to check out.
Oh, no.
So, Cole, fortunately, the biopsy shows that your mole is malignant. You have melanoma.
Skin cancer? Oh my God, Cole.
Oh, snap, I got a funky cancer mole.
How'd you know it was gonna be malignant?
Oh, I didn't. I was prepared for both ways. Check my rhymes, cause my mole is benign.
Yep, there you go. Oh, good times. Oh, Scrubs. You went downhill very quickly. Alright. So, other things that impact whether or not you recognize your symptoms is if you're under stress. If you're under a lot of stress, well, guess what? You are going to likely interpret your symptom, or excuse me, recognize your symptoms pretty dang quick. Okay? And that is because, as we discussed at the beginning of the semester, stress aggravates stuff that might be lurking underneath your skin, okay? Right? Because it reduces the ability of your immune system to operate. And so if you've got a microbe that's being held at bay, and then you're under a significant amount of stress, well then that microbe's like, free for all, woo! And then, you become sick, right? So that's an aggravation. It can also precipitate how you might get sicker, how symptoms might develop faster. Again, immune system being decimated by stress could lead to a more rapid accumulation of cancer cells in a tumor, right? And if that tumor metastasizes and expands beyond your where the cancer started growing, then that becomes an issue, because then whole systems will begin to shut down. So stress will precipitate or aggravate symptoms, which will make them easier to recognize, right? So we're still talking about recognition, and so the stress then is activating symptoms, and then they become easier to recognize, okay? Mood also plays a important role in whether or not you detect and recognize symptoms. So people, and this is pretty straightforward, I think this is pretty intuitive, in the sense that if you're in a bad mood, right, explanatory style tends to be more pessimistic, right? And symptoms and activities symptoms are recognized at a sharper rate, at a faster rate, and activities that are meant to relieve those symptoms generally are viewed as inconsequential or unhelpful. Okay, so people in bad moods or people who are pessimistic can recognize their symptoms, as the neuroticism thing, but they're less likely to seek treatment, which is what we're gonna talk about later. Less likely to seek treatment because the pessimism says that nothing's gonna help. I'm just gonna sit here and die slowly. Nothing can help me, right? That's probably what you feel like when you have a really bad fever. At least I remember having the worst fever I've ever had in my life. It was 104.3. My temperature was 104.3. And I felt like I wanted to die, because that sucked. 104.3. That's danger. That's just below danger territory. That's just below, whoa, we gotta get this person's temperature down, like, right now. Otherwise, their body is gonna start breaking down. So that sucked. And that'll feel like nothing's ever gonna make this better. That's kind of what I felt like, right? So that's recognition of symptoms. Now let's take a different approach. Now we'll say you've recognized the symptom. Let's interpret it. What's the interpretation that I'm gonna make about it? And the interpretation is gonna lead to the behavior. Recognizing doesn't lead to behaviors about seeking treatment. Interpretation leads to behaviors about seeking treatment, okay? And interpretation is by far one of the more psychological things that we will talk about in this set of material, okay? Because everything about your prior experience with the symptoms, okay, whatever those symptoms might be, okay, and your expectations of how it will be resolved will be the foremost features of how you make your judgment on about what behavior you're going to do, whether it's to just wait and see, seek minimal help, or seek maximal help, right? Whether you wait for a doctor's appointment or you go to the emergency room, right? So those sorts of things. The interesting thing about symptoms is that really one of the only motivating things is pain. That's why I underlined it. Okay. So, pain. The great motivator for seeking treatment in a care setting. the great motivator. It's perhaps the greatest motivator. Do you have pain somewhere? Is there a pain in my ear? Is there a pain in my throat? Is there a pain in my arm? Is there a pain in my genitals? Is there a pain in my foot? Is there a pain in my eye? Is there a pain in my mouth? Is there a pain in my head? Anywhere there's pain, it's likely because your tissue isn't working properly. And if it's not working properly, then you should probably go seek treatment if it's not working properly, right? The other reason that you might go and seek treatment, the interpretation of the severity, the seriousness, is if it's interfering with your daily activities, right? So you could say things like fever, that it's going to interfere with your daily activity of just being a normal human being. But do you seek treatment every time you get a fever? No, it's probably because we know what takes care of a fever, right? We'll take an NSAID, right? A pain reliever. That reduces inflammation, and it also reduces inflammation, which would then reduce a fever. So the symptoms interfering with daily activities, it has to be something that's really crucial that interferes with daily activities. So let's go back to 50-50, for example. Right? So he had pain. We can take that one out, right? Because he was having back pain, right? But he was also struggling with sleeping, and he was then he had some other issues here and there, right? And so that's why he finally goes to the doctor, because those symptoms were interfering with his daily activity, not to mention the amount of stress his brain was, or his spine was under, right? Because he had those, he had the sarcoma in his spine, right? So these are the two major things that are going to lead to severity judgments, right? How much pain does it cause? Is it something that I can work through or not? Okay. So one of the first things that you'll engage in with interpretation are the thoughts, cognitions about the symptoms. Okay. So we're going to use what's called the common sense model of illness. It is the name of the model. It's not just the model of illness and it's just like common sense. No, Leventhal and colleagues actually called it the common sense model of illness. Okay. And that's because it reflects common sense, or at least what they viewed as common sense. Okay. And the features of the model are these, right? So the identity, the causes, the consequences, the timeline, and control/cure. So identity. This is identifying the symptoms. Okay. The idea behind, sorry, let me back up. I'll mention identity again. So the reason why it's called common sense illness, I forgot that I had written this down, is that people hold implicit common sense beliefs about their symptoms, illnesses, in organized representations, or what we would call schemas. Okay, so schemas, if you've had COG, then you probably have learned about schemas. Okay, so these are organized representations. So these bullet points here that I have up on the slide are the schemas. Okay, so the identity of the symptoms. Okay, the identity. So I need to identify the symptoms. That goes back to the recognition slides, right? So I need to identify what the symptoms are. Do I have a snotty nose? Am I sneezing constantly? Am I coughing? Does my back hurt? Does my head hurt? Other symptoms include, lots of things, right? My ear hurts. I have a fever. All of those things, right? So first we need to identify. The next thing we need to identify is the causes of those. Okay. So if you get a fever and then you start vomiting, you probably think to yourself, okay, the cause of that is likely a stomach bug, right? A norovirus, maybe. Norovirus, right? So that we have understandings of the different kinds of bugs that might cause that, right? But if I don't get a fever and I'm vomiting, maybe I ate something wrong, right? Maybe I have an intestinal bacteria that came from foodborne illness, right? Or food poisoning. Okay, so we assess the causes, where we got it from, that sort of thing. What are the consequences of this illness? Now that I've identified the cause, what's my outlook look like? What does my future look like? Am I going to be out of work for a week? Is this going to get handled in a day or two, right? So with stomach, I'll take my stomach bug example. So if you've had the stomach bug before, you probably have also considered it a 24-hour bug, okay? And that's because it, generally speaking, either vomiting or diarrhea, it gets flushed out of your system, okay? And it doesn't, generally speaking, attack any other. It's good. It gets cleared out pretty quick, one way or the other, out of either side of our donut, right? As I've mentioned quite a bit. So the consequences. Okay, it's going to be over in like a day or two. Those are my consequences. I just have to get through these next couple of days. Yes, vomiting or scromiting is unpleasant, but I can get through this, right? Versus something like, what are the consequences of the pancreatic cancer that I was just diagnosed with? What are the consequences of that? Well, my pancreas is probably shot. Can this be salvaged, etc., right? What's my prognosis? The timeline goes hand in hand with consequences, because that's kind of part of it, right? So the 24-hour bug, the norovirus stomach bug, the stomach flu, even though it has nothing to do with influenza. The timeline, okay. A day or two, and then I'm on the mend. No more vomiting, no more diarrhea. Woo! Versus a chronic illness. Versus something that's going to last for a lifetime, right? It's a terminal illness, something that's going to actually kill me. Right? What's my timeline on that one? And then that bleeds down to control, cure, right? So cure would go for something that either fixes itself on its own, right, through either natural immunity measures or things like antibiotics, right? Or and not even something like an antiviral, because antivirals just reduce viral load, it doesn't actually kill the virus. But things like antibiotics or other remedies or other cures, right? Antiparasitics will kill a parasite, get rid of it, you don't have to pull it out. Surgery is a cure, right? If you take the thing out that's damaged, then you've, like for appendicitis, for example, you take the appendix out, boom, done, right? Or is it a control thing? Okay, am I gonna have to maintain this over the course of my life? So these are the thoughts that we have when we recognize our symptoms and then thus try to figure out what behavioral actions we need to take. Okay. I'll say only. Yes. Among the things that we think about with relations to the common sense model is the stuff that happens to us frequently, okay? And so there are 3 kinds of illnesses that affect us consistently. And I mean us by people. I just mean people in general, right? So things that happen acutely, right? They come and go. We don't, generally speaking, die from them, though people do die from them. Acute illnesses. This is something like the flu, what the influenza virus causes. You can also include the COVID-19 as an acute illness, because it is acute. It comes and it goes, hopefully, right? But it can also kill. Still doesn't change the fact that it's an acute illness. Chronic illnesses, on the other hand, last for a lifetime and generally speaking cannot be cured. Okay? Chronic illness is something like heart disease, right? If you're diagnosed with some form of heart disease, it's likely that you'll carry the heart disease throughout the rest of your life, and it might be the primary reason for your death. Okay? Cancer is a chronic illness. HIV is a chronic illness, or AIDS is a chronic illness. So these things last for lifetimes. COPD, spinal injuries, lots of things, autoimmune diseases like lupus or diabetes type 1, diabetes type 2, also, actually both kinds of diabetes, are chronic, right? So these things appear and then they don't go away. Okay, so that's what chronic is. And then the last kind of illness that we interpret is what's called a cyclic illness. You can call it a cyclical one, but it's technically cyclic, okay? And these illnesses are in a cycle of there, not there, there, not there, there, not there, okay? And I suppose one of the best examples of this is herpes, genital herpes, but we could also just say herpes in general. All herpes simplex or related viruses. Okay, we do have vaccines for some of them. So you either are like me and you got chickenpox as a child, or you received the chickenpox vaccine, like my children, because that was developed in between the time that I was a kid and they were kids, and so you may have gotten the chickenpox vaccine. Still a herpes virus. So because I did not get the chickenpox vaccine, my body is still open to a related herpes virus, which is cyclical, called which is the herpes virus, the herpes zoster virus that causes shingles. And I actually had shingles when I was a kid, when I was a teenager. Boy, do they suck. They do suck. So I have the potential to get shingles when I'm older, when my immune system isn't so fine and dandy, right? But we can also talk about again, genital herpes, herpes simplex 1, herpes simplex 2, oral herpes, right? So cold sores, that's cyclical, okay? Genital herpes, so if they appear on your genitals, that's also cyclical. So if you have symptoms and then you treat those symptoms and they go away, but then they resurface because there is no cure, then that's considered cyclical, or cyclic, sorry. Yeah, Marissa, you had them? Yeah, they were no fun. I had a fairly mild case. I had a small patch on my back. They sucked, but shingle, I mean, if you have a severe case of shingles, it is unpleasant. If you thought chickenpox sucked, if you ever had chickenpox, anybody ever had, I thought chickenpox sucked. I have chickenpox scars. Okay. Yeah, generally speaking, they don't occur at that young of age. It's generally speaking, a middle-aged to elderly affliction, but can happen. I got it when I was like 14 or 15, something like that. So rough. Here is an expanded flowchart model. An expanded flowchart model of all the things that we've talked about. Okay, so I'm not going to go through all of it because we are running low on time, and I do want to bring up one more thing. So this is a good chart to know. I think it summarizes everything that I've talked about and all of the connections between, whether or not you can recognize and then what interpretation will lead you to. Okay. The last interpretation that I want to leave you with is using the internet. Okay. I mentioned this at the start, right? WebMD or other, right? Other. So about 6 million Americans, again, just Americans here, about 6 million Americans on any given day look for healthcare online. That's a lot. That's a lot. Here's an XKCD comic of what it's like to you know, look at what WebMD has to say. How many of you do go on WebMD when you like don't recognize the symptom? Come on now, be honest. Seriously, this is what gets me. I wasted so many hours on WebMD worrying about the rash on my arm. Yep. Just don't walk in front of jet engines. Okay? So, lots of people look on it. The important thing to know is where you're getting the information from, right? So, what I would say is if you want to fall down a large rabbit hole, like Alice, right? Like Alice, then what I would suggest is doing a comparison between these two websites. WebMD.com, 13 flu myths, right? And this is specifically the influenza, that is seasonal, right? Seasonal flu. Versus VacTruth.com. 8 damn good reasons. And so the rest of the title is 8 damn good reasons not to get the flu vaccine. Okay. Just compare how the information is presented on both websites. I'm not gonna do it now. But yeah, I think it's worth it. But just remember what a website VacTruth is. Courtney suggests Mayo Clinic. Yeah, Mayo Clinic is especially if you search for symptoms on Google, Mayo Clinic pops up right at the top of Google's search results because of how awesome the Mayo Clinic is. So yeah, just recognize that when you're hanging out. Now, again, I don't have time to show this. This is from Last Week Tonight. I just really enjoy how John Oliver has these long pieces about not often discussed things. So this was from a couple of years ago, I think from season 4, 5 maybe, of Last Week Tonight, where he talks about mental health and the stark reality of mental health, the stigma associated with it, and how mental health, and as you saw in the flowchart, plays a role in whether we can recognize symptoms and how we interpret those symptoms. So jump on YouTube and watch this piece if you haven't. All you have to do is type in Last Week Tonight mental health and it'll bring it right up. As far as like having something to do, having something to watch, I think this is really important. And I wish I could show it to you. If I had more time in class, I would have played it, at least maybe the first part of it, just to get you get the idea of what it is. But yeah. I think you should watch it. It's really good. It's really good, and it's well sourced too. It's not great information. It's not fun. It's not pleasant information. That's why I wrote frank mental health facts, because, but I think it's something that's worth watching if you haven't seen it before. So we're gonna end there today, and we're gonna pick back up with this chat on Wednesday, and we're gonna start with seeking treatment and gender. Okay. So that is where we are going to end for today.